Good morning and welcome to this refresher course on musculoskeletal pain, mechanisms and assessment. My name is Thomas Graham Nielsen from Aalborg University in Denmark, and I have the privilege of organizing this refresher course. I'm also very privileged that three of my good colleagues, they accepted an invitation to help with this course, because we're going to touch on many different things here this morning. We will first hear about some of the basic manifestations and basic signs in musculoskeletal pain, and that will be Professor Hans-Georg Schaible from Jena in Germany. Then, after that, I will touch a little bit upon how can we assess some of the mechanisms in humans, and it will be a mechanistic approach, so we will see how we can deal with some of these particular mechanisms in human musculoskeletal pain. Then we'll have a break of about 30 minutes, and then we will have a session more focusing on how to manage pain, and Professor Serge Perrault from Paris in France, he will tell us about management of musculoskeletal pain, and that will be 7 steps to heaven, and I'm really looking forward to that part, especially the last thing. And then after that we will have another focus, that's Professor Michelle Sterling from Brisbane in Australia, where we'll have a lecture on how physiotherapy acts in musculoskeletal pain settings. We will give about 30 minutes presentation, a little bit less, and we will encourage you to have questions ready for us so that we can have a discussion on the various issues. And these questions will be asked immediately after each presentation. So without further ado, I would like to welcome Hans-Georg Schaible to present on the basic mechanisms in muscle and joint pain.
I will focus on the basic constructs for muscle and joint pain. That means I will address neurons which are involved in muscle and joint pain at different levels of the nervous system, peripheral level, spinal level, and also a little bit the supraspinal level. Muscle and joint pain are not totally overlapping in the nature, because many aspects are typical for muscle pain, for example, pain during exercise, and other types of pain are more important for joint, for example, osteoarthritis. So the research and also the topic is not totally overlapping, so I will try to cover both a little bit. First of all, muscle, skeletal muscle as well as the joint are really strongly innervated by many nerve fibers. Both of these structures have thick myelinated nerve fibers, which are mainly involved in things like position sense and also control of movement and so on. This is not the topic of this talk. Both of these structures are strongly innervated by thin myelinated delta and unmyelinated C fibers. They supply sensory free nerve endings. Many of them are nociceptors, but not all of them, as I will show you. And not to forget, we have a lot of unmyelinated fibers in muscle and joint nerves, which are belonging to the sympathetic nervous system. Now, how are muscle nociceptors and joint nociceptors or joint fibers studied? The typical approach is shown here. This is by a picture from Menze, who has done a lot of work on this muscle afferents. Here is the muscle. They are recording from single fibers from a muscle nerve. They do electrical stimulation, identify the fibers as A delta or C fibers, and then they apply local stimuli to the muscle and characterize the response properties of the fibers. For example, they use local pressure and other stimuli, for example, injection of compounds, and they record the response properties. So in this case, they applied pressure to the muscle, and they found that there are obviously 2 types of units, and I'm talking now about C fibers and A delta fibers. We forget the big ones, the A beta fibers and so on. And they found that a large proportion of them have a high threshold for mechanical stimulation. And there is another portion of these neurons which have a relatively low threshold to this mechanical stimulation. So the high threshold ones are usually considered as the typical nociceptors of the muscle. And the basic idea about the nociceptor of the muscle is shown here. Typically, a nociceptor of the muscle will not respond to touching the muscle, will eventually give a little response to moderate pressure to the muscle, but it will really respond to noxious pressure squeezing of the muscle, which is a painful stimulus. It would also not react to muscle contraction, which is usually not painful, and passive stretch, but there is a response to analgesic substances. Now, this is a typical response of a muscle nociceptor. Similar type of responses are found with the joint nociceptors. Here, this is our work, we use rotations of the joint, and a typical joint nociceptor with a high threshold responds only if the joint is over-rotated against the resistance of the tissue. So it's really a painful stimulus. There is usually no response to any innocuous movement, just movement in the working range. And this is typical, of course, for a joint nociceptor. However, it's not all black and white. As usual, we find not a strict of strictly the same types of fibers. For example, this is one which shows a little response to innocuous rotation to the end of the working range, but the strongest response in the noxious range. So we still consider them as nociceptor because they have their main response in the noxious range. And we have other fibers which do not respond at all to mechanical stimuli as long as the joint is normal. These are, as I will show you in the next slide, the so-called silent nociceptors. The silent nociceptors are a group of C fibers mainly, which do not respond at all to any mechanical stimuli as long as the joint is normal. However, they begin to respond to stimuli when the joint is becoming inflamed. So initially, you just don't see any reaction to stimuli, neither to innocuous nor to noxious ones. And after induction of inflammation, these units begin even to respond to flexion and to rotation and things. So this is a group of silent nociceptors coming into play only during inflammatory conditions. Now, what about the muscle? Muscle fibers, the nerve fibers in the muscle, which are shown here, the low threshold ones. Are these also nociceptors or not? Now the point is, these low threshold fibers, mechanically low threshold fibers, they respond to the same chemical stimuli as the high threshold fibers. So is it possible that all of them are nociceptors? Now this is a consideration made by some people. They say that nociceptors are fibers which respond to noxious mechanical stimuli, respond to chemical stimuli, and whose stimulation elicits pain, whereas the other ones, which have a low mechanical threshold and still have a response to chemical stimuli, they rather measure other things. They may measure metabolic state, vascular tone, and the question is what sensation is evoked by them, or is there any sensation evoked by them? This is not definitely known at the end. The idea is that it may evoke fatigue or what else. So there is certainly some unclarity so far. Are nociceptors and ergoceptors really totally distinct groups of fibers? Now usually many nociceptors respond to mechanical stimuli and chemical stimuli. I have already addressed this. What about thermal stimuli? In fact, thermal stimulation of muscle and joint afferent fibers has not really been well studied. There are few data on muscle nerve fibers. About 20% of them respond to heat and some respond to cold, but we don't know much about the significance of these responses. So we forget about the thermal stimulation for this talk because I can't tell you much about this. Now going back to the chemosensitivity. Now the chemosensitivity is quite important. There are two main purposes for chemosensitivity. The first one is shown here. There are many mediators which can directly excite the nerve fibers at a short latency. They evoke action potentials, and in awake humans, they would evoke pain immediately. This pain is usually short-lasting. Now, typical stimuli, for example, hypertonic saline, low pH, and a few of these compounds. When you apply these, they evoke pain, and they may or may not induce some mechanical or chemical sensitization for a long time, but this is really not important. By contrast, Other mediators sensitize sensory fibers from mechanical stimuli for a long time, and they evoke a long-lasting allodynia and hyperalgesia, hours and days. And you see these are other mediators such as nerve growth factor or inflammatory cytokines. So we have different types of chemosensitivity with different significance for the muscle and joint pain. How is chemosensitivity at all realized in nerve fibers? Basically, we have two possibilities. Either the chemical compound will directly activate an ion channel, for example, A6 for protons, or ATP excites the PTX receptor, which is an ion channel. And the other possibility is they act on receptors in the membrane and activate second messenger systems which then influence some of these ion channels. So these are the basic possibilities how the chemosensitivity is realized in such a nerve fiber. Now, first of all, which mediators are involved in the ischemic pain, which is a typical pain in muscle, which you can evoke quite rapidly under the suitable conditions, the ischemic contraction. Now, there is a lot of work has been done, and these are some of the mediators which seem to be important for this type of pain. And you see in the next slide, for example, if you apply lactic acid, this is now a cardiac C fiber, but they're similar in skeletal muscle C fiber, within a few seconds, you can evoke action potentials. Now, this is a typical type of this immediate action of a mediator, which evokes just pain shortly after application. And it goes away when the compound is away. So this is now a long-lasting event. How is are the muscle nerve fibers equipped with receptors for this stimulus? Now you see this is again an analysis of Menzies' laboratory. They have found that 60% or up to 80% are excited by ATP, which is released just by ischemic contractions and some injury, of course, and then pH, low pH, capsaicin, and so. So these are the compounds which are released during ischemic contractions, yeah, and you see that for them there are many receptors and ion channels available, for example, ISIC channels and PTX for the ATP, and also this is the capsaicin receptor, which is sensitive to pH changes. Again, you see here the big overlap, the high threshold mechanosensitive units and the low threshold mechanosensitive units, they show the same chemosensitivity, just supporting the concept of nociception and ergoception which I have shown you. Interestingly, they did not find much effects of these other mediators which I mentioned for the long-lasting effects. They concentrated on NGF. You will see NGF a little bit later, what it means. So we come a little bit more to longer lasting pain states in a muscle, and this is a delayed onset muscle soreness. Now this is probably we know all of it by our own experiences. It appears about 1 to 2 days after exercise and declines within 2 to 7 days. And then it's okay, it's no disease at all, it's okay. It's a transient experience lasting, however, for some days. It is characterized by movement-related pain, no thermal hyperalgesia, no spontaneous pain. Now, how does this work? There has been done some very nice work by this group, Mizumura and co-workers, and they proposed the following model. You have here a contraction under unphysiological conditions. This contraction may release some mediators such as adenosine, which act on the blood vessels in the muscle. And these blood vessels can then liberate some mediators, here for example the bradykinin. The bradykinin by itself can cause short-lasting pain, but here you see what's happening in the muscle cells. The bradykinin acting on B2 receptors will cause an upregulation of COX and prostaglandin receptor, and then these growth factors come into play. And the basic idea is that the long-lasting effect, this muscle soreness, are basically evoked by these mediators by GDNF and NGF. Interestingly, this one is mainly working on R-delta fibers, and the NGF is mainly working on C fibers. So this is a transition from acute ischemic contraction pain eventually, or even if it does not happen, you can have still then later this soreness. And you see that here other mediators are coming in. This is just one of these slides which I showed. They show the response magnitude of these fibers after NGF, and you see they cause a long-lasting minutes and even hours, 100 minutes and more, in increase of the responses. Now these are really different effects from those of these short-acting mediators. And interestingly, the same for GDNF, however, this mainly affects the E-delta fibers. Now, what about the chemosensitivity of the joint? Now again, nerve growth factor seems to be an important molecule. This is the famous experiment by this group of Lane and co-workers. They treated for the first time patients with OA with an antibody to NGF. They gave just the one injection of NGF antibody at this time, and what they found is that OA pain for many weeks showed a significant reduction, much more reduction than it was ever found with simple analgesics. Sometimes they apply a second type antibody. So this shows at least that NGF seems to be also very important for joint pain, and there is a lot of evidence for this now that NGF is involved in long-lasting pain states also in the joints. We think that another group of mediators is also quite important, and these are the pro-inflammatory cytokines. Joint diseases are usually of in the rheumatic field or osteoarthritis, and in all of these fields, the cytokines are very important. And so we started to study mainly the cytokines and looked how they act on these receptors. This is our idea. We know that the pro-inflammatory cytokines in the joint, they cause the inflammation, and this may, in an indirect way, cause the pain. Involved here are prostaglandins and things like that. However, we think that there is also a direct way of the pro-inflammatory cytokines, because many of these nociceptors of the joint, they express receptors for these cytokines, and the cytokines can directly act on these nerve fibers as well. So you see here just a few examples. We have localized a lot of TNF receptors and also IL-1 receptors and also for other cytokines in dorsal root ganglia, showing that cytokines can directly act on the neurons. Another typical thing is that these cytokines also cause these long-lasting changes. This is an injection of NGF in a totally normal knee joint. And we record here a fiber several hours before and after this injection, and you see the responses to innocuous and noxious pressure before, and then we inject this compound, and you see that the responses are slowly increasing over time. And the most important thing is these increases of the responses, they are quite persistent, lasting for many hours, as long as we can record. We have this increase. So that means these are really compounds, the cytokines, which cause a long-lasting sensitization to mechanical stimuli. This is what the clinicians see. Now we looked also to other cytokines. I cannot go into detail in all of these aspects. Basically, many of them sensitize C fibers in the same way. However, the response of E-delta fibers, that's another thing, can differ quite a lot. So the total effect of a cytokine may be pain or hyperalgesia, but this is not always the case. We could identify some, and people identify some, which are clearly involved in pain and whose reduction is causing pain relief. And this is, for example, the TNF neutralization. This is now known for several years. That TNF neutralization is an excellent treatment for rheumatoid arthritis. And as these people showed here in humans, the reduction of the pain in the rheumatoid arthritis after application of antibodies to TNF appear quite rapidly within a day. So the first reaction in responders is a pain reduction. So again, supporting the strong impact of the cytokines on the pain system. Now, for many reasons, we believe that different cytokines are involved in different types of hyperalgesia. without going into details. This is a complicated analysis. And how is such a pattern possible? In general, we believe that different cytokines have different receptors in the membrane of a nociceptor, and they can affect different target sites. So depending which of these ion channels are affected by the cytokines, it will elicit more mechanical or more thermal hyperalgesia. This is a basic concept which I will not explain you in details now for lack of the time. I just want to mention that muscular skeletal system contains, of course, the muscle and the joint, but also the fascia and things. And I just want to show you that people also started to innovation of the fascia. This is also Taguchi and Mitsumura. They can display the fascia and they can record the response properties of fascia and find that fascia neurons also respond to bradykinin and to heat and other stimuli. So nociception is in the whole deep tissue probably working in many different structures. Now, this was the periphery. Now, what happens in the spinal cord and higher up? A typical thing is that these nociceptors, which I have shown you before, the muscle nociceptors, the joint nociceptors, they project usually on the same spinal cord neurons. So we have here really a convergence from different sources on the same spinal cord neurons. Basically, we see two patterns. These are neurons which respond only to influx from joint and muscle. They have no skin input, but more of them have in addition an input from the skin. Often the receptive field in the skin can be different from the receptive field of the joint. For example, it can be on the foot. If you have a neuron with knee joint input, the receptive field in the skin can be on the foot. So these are highly convergent neurons. So in a way, we study different things in the periphery, but when we study the spinal cord, there is a lot of convergence of the research on muscle and joint pain because of this organization. Typically, neurons with input in skin and deep tissue, and also some neurons with only deep input are found also in the thalamus and in the cerebral cortex, so this seems to be a common principle of organization of the deep somatic pain. Now the A delta muscle nociceptors project to lamina 1 to 5 mainly, the C fibers terminate mainly lamina 2, and I show you also the projection of the joint nerves. We find here interestingly always a projection to this very superficial laminae and also to the deep laminae corresponding to the projection patterns. And when we look which neurons are showing activity by CFOS labeling, so you see again we have two main fields where these neurons are activated, the superficial dorsal horn and also a large proportion of neurons in the deep dorsal horn are activated during such a joint inflammation. And similar things have been shown for muscle inflammation. A very important thing is that after injuries or inflammation in the periphery, there is very early starting a process of central sensitization, spinal sensitization. That means neurons which get this information from the joint and also the adjacent muscle, they change their response properties. That means the responses to joint stimulation after induction of inflammation at this site strongly increase, but in addition, the receptive field of such spinal cord neurons is expanding. And this probably has a good correlate in studies in humans where the pain area is shown here after application of a local pain stimulus at this site. So probably we'll hear more about that in the next lecture. Now, what do we think how this happens? Without going into many details, these neurons with input from the joint, they have always also weak synapses from adjacent tissue outside, and when the neuron is becoming more sensitive by the input from the inflamed joint, if neuron becomes more sensitive, also these synapses at the periphery, which connect the fibers from the periphery, are able to excite the neuron in suprathreshold way, and that means that the receptive field can expand. and also we'll probably also hear about this in the next lecture, the large expansion of the pain in different areas upon a local disease process. And consequently, if neurons show an expansion of the receptive fields, Menze and his co-workers, they have found that on average more neurons in a spinal cord of an inflamed animal show responses to stimulation of these structures than in the normal situation. So there is really a strong recruitment process which collects many more neurons for nociception under inflammatory conditions. Now, I could tell you a lot of mediators, but I want to make it relatively short. We know that there are several mediators involved in decentral sensitization. For example, very important are the NMDA receptors for glutamate. You can block the NMDA receptors with ketamine, and as you see here, you cannot change the responses of these neurons when you apply ketamine. So this really prevents sensitization, whereas it works. Sensitization means that the responses increase after induction of inflammation very rapidly in the absence of ketamine. So ketamine NMDA receptors are quite important. Also important are prostaglandins, which are also synthesized in the spinal cord during peripheral inflammation. They also contribute to this process of central sensitization. And there are many more players. Just as an example, we found also effects of interleukin 6. Interleukin 6 is released from neurons in the spinal cord and also from glia cells. If you block interleukin 6 signaling, you can also see a reduction. The normal increase during inflammation of the responses is attenuated when you block the IL-6. So it's a complex process, again, having different mediators and different time ranges which are important. Just one comment to another aspect of this central sensitization. Central sensitization is, of course, very important for the pain. It just increases what's coming in from the periphery and helps to increase the pain. But one should not forget that the joint is also innervated by efferent means. That means the neurogenic inflammation part and also sympathetic fibers which innervate the joint. And we and also other groups have seen that the activity of the spinal cord is also important to some extent for the strength of inflammation which is induced after a challenge. So if you reduce the activity in the spinal cord, if you reduce the central sensitization process, you can also reduce to some extent the inflammatory process in the joint itself. This is shown by these data. Last point, finally, we experience the pain in the brain. The first study who has studied the mechanisms in the cortex which are responsible for joint pain are by Kulkarni and co-workers. And they found basically that the stimuli in the joint during inflammation, they activate the pain matrix that we know from other fields, cutaneous pain, and so on and so on. In particular, they could activate, for example, the cingulate cortex, and they could activate the insula, and also, very interesting, the amygdala, which is involved in the generation of fear. This is another picture showing different aspects, insula activation and activation of amygdala. This is a PET study, and the cingulum activation. So the message is joint pain, muscle pain, activates the pain matrix very heavily. To which extent the pain matrix is differentiated for cutaneous and muscle and joint pain, this is not known at the moment. We don't know whether it's exactly the same or whether there are differences. This is still open. Further analysis have shown that also in the brain, many things are changing during arthritis and diseases of the musculoskeletal system. For example, it was described that there is a reduction of the gray matter, as in many other pain states. And the last point, that there might be also in decrease of the descending inhibition, which keeps to some extent the spinal cord under control. So you see here in this slide that at all the levels of the neuroaxis, changes are going on during muscle and joint pain. The very last point, and then I'm finished with my talk, is I just want to show you one slide about the descending inhibition. Descending inhibition you know probably, the pathways, and there is one interesting aspect shown very long time ago by a group of Mense. They showed that the descending inhibition is much more potent for the deep inputs than for the skin inputs. Now this is another differentiation. The deep input is much better controlled from the brainstem, obviously, than the skin input. And if you get rid of this inhibition, this is another explanation why joint and muscle pain may be so strong. So, with this last slide, I want to close my presentation about the basic constructs of muscle and joint pain. I hope I could show you some things, and I'm now ready to take some questions. Thank you for your attention.
So thank you very much. Any questions to Hans-Georg on these very fundamental mechanisms? If that's not the case, then I'm sure we can also take them in the break later on if that's needed, because otherwise I'll just walk over there and continue from there. So thank you very much.